now that we are seeing so many people live, very long and in general, very healthy lives. As Barbara mentioned, I'm a neurologist and I'm a psychiatrist. I run the Penn Memory Center. I do research in laboratory where we look at brain tissue from people who have died of various conditions. We also run clinical trials of medicines that may help with memory and thinking and Alzheimer's disease. We are located in two areas on the campus of the University of Pennsylvania, one of the older buildings and one of the newest, and actually now, as of today, the newest building on campus. We were trying to get renovation for this building, but they said, why don't you just move to the new space, the Perelman Center for Advanced Medicine, and they put us in between cardiovascular medicine and cancer. These are the two huge diseases, and it shows how important things like dementia are becoming to a major health systems. People routinely live into their 80s, and actually in a few decades, there'll be more than 1 million people over the age of 100, and so we will become a 5-generation family society. It won't be uncommon for that. Right, the statistic that I heard about a year ago that I was blown away, that a baby born now, in 2000 or more, has a 50% chance of living to 100. We need to understand. And I think the beauty of that is that we are living longer and healthier lives. But one of the challenges that we have had, and the reason why things like Alzheimer's disease are so prevalent now and so problematic, is that we haven't been able to yet budge the increased rate of developing Alzheimer's disease as people get older. So, I like to talk about what are the things across the lifespan that we all can experience. Now, everyone, as we get older, has more of that tip of the tongue phenomena. You just can't, remember someone's name. You know the person, but the name just doesn't come. We all have more of this experience of walking into a room and you can't remember why you walked into the room. We are all slowing down in terms of being able to multitask, keeping a bunch of things going in our head, remembering a phone number as you're crossing the room while at the same time someone's talking to you, and it's hard to process information as efficiently as we used to. Now, audiences are getting more sophisticated, but let me just ask, when do you think that these things start to occur, that these real senior moments become a real problem? Yes?
Late 70s.
Late 70s, okay. Yep. You are an optimist. Yes?
Late 30s.
Late 30s?
No.
Okay.
After menopause.
After menopause. Menopause is a big thing. But actually, going back and looking at when changes like this occur, I was extraordinarily surprised. I don't know if people in the back can see this, but it looks like we peak at around age 20 in terms of our memory and cognitive abilities, and it's kind of downhill from there. So in terms of our processing speed, our short-term memory, our long-term memory, what we call working memory, keeping a bunch of things going on in your head at the same time, these all do, and this is just life, they get slower and harder as we get on. Some things like financial literacy and financial decision-making is becoming a really, really big issue as people get into their 70s and 80s. So your ability to sort of make financial decisions, so they have questionnaires or surveys, and they call this financial literacy. So if I were to tell you that you had $100 in a savings account and an interest rate was 2% per year after 5 years, how much do you think you'd have? Would you have $102, more than $102, less than $102? And people have more trust. This is a simple thing, but people have more difficulty thinking about these types of things. Then when you factor in like rates of inflation and return on investment and how to balance those, people start to get very confused. And also people in general, as we get older, we have more trouble understanding financial risk. And yet at the same time, people feel that they're even better than they were when they were younger at making financial decisions. This has become, I just put this slide in this morning because I think it's an important topic. And it's something that we're thinking about for a number of reasons, because we're now getting approached at the Penn Memory Center, for advice from Wells Fargo, because so many older adults where there's a large concentration of wealth. I mean, you've built your wealth for your life. They're seeing that people are making decisions that are just out of character. My daughter-in-law to be's mother, she's a lawyer at Vanguard, and they don't know what to do because they see people who have had a certain pattern of investing for their whole lives, and then they're shifting money, they're investing in risky things, and she doesn't know because people obviously are autonomous, they can make their own decisions, yet the company, Vanguard, is seeing that they're making decisions that are out of character for their whole life. And she's wondering, and these companies are wondering, what's going on here? What's their liability? Should they let someone make these financial decisions and shift their investments, or should they not? So, there are all these, we talk about major things like Alzheimer's disease, and which clearly is a major disease, and that is the bulk of what I'll be talking about today. But even, these more subtle changes, how do we understand them? What's happening in the brain that might account for someone to make a bad decision and be susceptible to a financial scam, versus, some of these other things like improving wisdom and social reasoning. These are the things that I find fascinating and very confusing. And I guess I want to provide some clarity today, but I'm also sharing some of the complexity of what we're trying to deal with and sort through from both a social, psychological, and medical perspective. So I talked about these trajectories and how memory and thinking does get change over time. And it looks like there's these nice, simple lines, and we're all following this trajectory. But in fact, if you look at any individual, the lines look more like this. So this is what we call a spaghetti plot for individual changes of memory and thinking over time. And there are some people that just continue very stable or even improve in terms of their memory as they get older and older and older. Some people have sort of a common slow decline. Then you have some people that maybe something happens, like they have a stroke, and all of a sudden, boom, they're quite impaired. And then you have other people that develop a degenerative condition like Alzheimer's disease, and they really start to decline. So we see a whole range of variability, and if you collapse that and average it all, you get that kind of declining line that I showed you about. But as I said, memory and thinking, while we all do slow down, or almost all of us slow down as we get older, it's happening in a narrow range, and it doesn't, and it shouldn't affect our day-to-day functioning in meaningful way. Maybe it's harder to kind of balance the checkbook, it takes you longer, but you're still balancing the checkbook. You're driving more carefully, but you're still able to make it to the store and do your business there and come back with the right things. I think from a health perspective, when we become concerned, it's when people start to have a significant, noticeable change, where they're struggling to keep things going. And when someone falls off this normal curve of memory and thinking, and we can, the family notices or they notice that, things are not right. We call that mild cognitive impairment, or MCI. And MCI is a condition that we're diagnosing more and more now as a significant change in a person's memory and thinking, more forgetfulness than is really ordinary or what they should be. But they're still able to manage their day-to-day affairs, but it's very, very effortful. If someone then gets worse, their memory and thinking worsens to the point that they can no longer remember how to get to the store when they're driving, or that they can't figure out how to pay the bills, or they're just forgetting to pay the bills, or they're paying the bills twice because they can't remember that they already paid the bill. Then we use the term, when it's affecting a person's functioning in a meaningful way, then we use this term dementia, okay? So that's what we mean by the term. People have heard the term dementia, and what we mean by it is when someone has memory and thinking difficulties to the point that it impairs their day-to-day functioning. And we are seeing as a huge increase in the number of people with dementia and dementia types of disorders. And there are a lot of different causes of dementia, as I'll talk about. And the reason why we're seeing such a large increase is because people are living to the ages where these disorders, dementia, becomes more common. That's the only reason. It's not like we're having an epidemic or an infection of Alzheimer's disease and other things. It's because we're living to that Alzheimer's disease gets more and more common, and other types of dementia get more and more common the longer we live, and we're living longer. And the figures now are about 40% to maybe, some people even think 50% of people in their mid-80s have dementia, okay? Now we're living into our mid-80s. That means half of people have dementia. This is a huge thing, and there are now over 5 million people with dementia in the United States. This is going to triple over the next few decades. It's now the 6th leading cause of death. Alzheimer's disease and related dementias, things like Alzheimer's disease, now is the most expensive disease in the country. It is now more costly to care for people with dementia than it is for all of cancer or all of heart disease. And because the numbers are just going to continue to grow and grow and grow, I think in 2050 the total national cost is going to be $1.1 trillion to care for people with dementia. And that's, I think, more than half of the total federal budget. So we have to do something to prevent this, to keep people functioning and productive longer. And so that's we need to improve the research for this. My own pet peeve, because I'm a researcher, I look at the National Institute of Health, and so even though Alzheimer's and related dementias are the most expensive disease in the country, the National Institute of Health spends $6 billion a year on research on cancer, and less than a tenth of that on Alzheimer's disease. So, not that cancer isn't important. It is. It's very important. But still, I think we need to make a judgment as to where we want to put our funding. When you look at all types of dementia, and there are many causes of dementia, so I think if any of you or a family member is having a problem with memory and thinking that you're concerned about, it's very important to get it checked out by at least your primary care doc, because there are a whole range of things that can cause changes in memory and thinking, some of which can be very treatable. If the thyroid gland is underactive, hypothyroidism can cause you to slow down and become forgetful. Vitamin deficiencies. Sometimes your stomach loses its ability to absorb vitamin B12, And if the vitamin B12 deficiency, that can cause memory problems. We're seeing that vitamin D deficiency can cause some memory difficulties. So I think it's really important that if you have some concerns about your memory, that you do get it checked out, at least by the primary care. And if nothing is really showing up, then perhaps a specialty evaluation is important. When we look at all causes of dementia, and I kind of put, there are well over 100 different conditions that can cause significant memory impairment and dementia. But in later life, about 50 to 70 or 80% of all causes of dementia is due to Alzheimer's disease. And I'll tell you what Alzheimer's disease is in a few minutes. Maybe 10 to 30%, and usually an overlap with Alzheimer's disease, could be related to mini strokes or vascular disease affecting the brain, and all the things like high blood pressure, sugar diabetes, high cholesterol, overweight, lack of exercise. These same things that can affect our heart health also affect our brain health, and can cause many strokes and the like, and that can cause dementia. Then there are other relatively rarer conditions. So the Parkinson's disease related, so Parkinson's disease and some conditions related to Parkinson's disease cause about 5% of dementia in later life. And then there's something called frontotemporal dementia, which is another 5%. It usually affects people a little younger. So this is what the pie looks like in terms of the causes of dementia. Now, Alzheimer's disease is the big one. And what do we know? How do we know about, what do we know about Alzheimer's disease? This is a picture of Alois Alzheimer, who was a psychiatrist and a pathologist back in the late 1800s, who encountered a patient who actually had an early onset of Alzheimer's disease. We do sometimes see people in their 40s and 50s who develop Alzheimer's disease. So this woman actually had an early onset Alzheimer's disease. Her name is Auguste D. And she started to show forgetfulness. She actually, she didn't recognize her husband. She thought her husband was an intruder, and she became very paranoid. He treated her for a number of years. She became worse and worse, and she did die in a sort of end stage of dementia, quite impaired. And when he looked at her brain tissue under a microscope with some stains that the Germans were developing at the time, these tissue stains, he saw these things, these black things that we now call plaques and tangles. And these are, we know a lot more about these plaques and tangles. We know that they are, that you can see them under the microscope if you do an autopsy of someone, a brain autopsy after someone dies. We know that they are made by some proteins that, brain cells and our whole body is made up of proteins and fats and carbohydrates and things. There are certain proteins that are normal that we all have, but in Alzheimer's disease, in the brain, they start to clump up and they become abnormal and they form these plaques and these tangles here. And when they form these plaques and tangles, they gum up the functioning of brain cells, and the brain cells ultimately die. And so the connections between brain cells die, and then the brain cells die. And that is what leads to the loss of first memory, because it seems to happen first in the memory areas of the brain. And then as the disease progresses, it spreads to other parts of the brain. And so we know a lot about these plaques and tangles, and still the only way we can be 100% sure of why someone is developing a dementia is if we do look at brain tissue under a microscope after they die, there's been a tremendous amount of work over the last 2 decades to see, can we use any fancy X-ray tests and all, or other types of diagnostic tests to see, are these plaques and tangles developing in the brain? And we're now at a point where different kinds of MRI scans, PET scans, I don't know if people know what PET scans are, it's a different kind of X-ray test, and even spinal fluid tests, which we do a lot of at Penn, we can actually measure the amounts of these abnormal proteins, these proteins called amyloid and tau, that are the cause of Alzheimer's disease. And so this shows us a scan of someone, and we have an Alzheimer that measures the amount of amyloid plaque protein in the brain. And this is the scan of someone who has Alzheimer's disease, and you can see the red that they have a lot of this amyloid plaque. This is someone, a normal older adult, without any memory impairment, who doesn't show any red. And these are 3 people with mild cognitive impairment. Now remember, mild cognitive impairment is when things aren't right, but they're not terribly wrong. And for some people who have mild cognitive impairment, they just go on, and then, that's just the way they are, their aging is. Some of them get better, but for some of them, mild cognitive impairment is the first stage of something that's going to get worse, which is Alzheimer's disease. And so with these people with mild cognitive impairment, we can now do these amyloid scans and predict better what their future holds. So this is someone who didn't have any amyloid with mild cognitive impairment, and in the next few years, nothing really changed, they were fine. This is someone who had mild cognitive impairment who did have a lot of amyloid plaque in their brain, and this person within a year or 2 got worse to the point that we would call them, as they had dementia. We are doing the same thing with the tau tangles. We have these new imaging methods to do that. We can do, as a very simple test in the clinic, without any X-rays or anything, a spinal fluid test where we can measure the amounts of this amyloid and tau proteins. And this is highly predictive. So I don't know if you can see this graph, but in people with mild cognitive impairment who developed some memory, they worried about their memory and they had some measurable difficulties. A person with a normal spinal fluid test over 5 years, less than 1% of them per year got worse in terms of their memory. Whereas people who had an abnormal spinal fluid test, virtually all of them got worse over the next 5 years. So we are getting better, based on our understanding of these plaques and tangles, we are now better at predicting, diagnosing and also predicting what the future is for people. These biomarkers are transforming the field, and what we know about them is that, no one wakes up one morning with Alzheimer's disease. It is something that has been occurring, probably growing in the brain for 10 to 20 years before someone has the first symptom. So, on the one hand, wow, this is bad. This, I may have Alzheimer's disease and it's developing. And we know that the amyloid starts to go up first, and then the tau starts to go up. And then the synapses, the connections in between brain cells start to deteriorate. And then only after that does someone have some memory difficulties. And then after that, will they have some day-to-day functioning difficulties. What this means is that the disease is progressing for a couple decades probably before a person has their first symptom. And what this means is that it gives us a big window to intervene, to change things. So if we can see someone is on a trajectory to develop memory difficulties, my watch is actually off, so just 10:15? Okay, so I want to leave a lot of time for questions, and I see I brought way too many slides. And so, oh, thanks. What this means is that there's a lot of room for intervention, and this is why I'm saying that, perhaps even more important than treating Alzheimer's disease, once the brain cells have died, we really should be focusing on preventing Alzheimer's disease, developing, identifying who's at risk, and then intervening at that point. And so the field is changing, and we are now beginning to use this term preclinical Alzheimer's disease. So this is someone who has normal memory and thinking, and yet if they got one of these scans or spinal fluid tests, we could say, oh, geez, you have some Alzheimer's disease developing in your brain. What can we do now to actually prevent that? And I'll be wrapping up my talk with one of the first national study now that we're involved in that is designed to prevent dementia in people who may have this. There's an interesting thing that something that I've been involved in for a number of years. There's a large study that we actually, in my laboratory, we do some of the pathology, the microscope work on this study. This is a large study based in Chicago called the Religious Orders Study and the Memory and Aging Project. And these are, so the Religious Orders Study is about 1,300 older nuns, priests, and brothers who are all normal when they come into the study to research. And they get yearly memory and thinking testing. And and some of them go on to live to 106, 108, sharp as a tack. Some of them develop dementia. Some of them develop mild cognitive impairment. Some of them develop Parkinson's disease. All of them have agreed to donate their brains after they die to be studied. And with these, we are able to measure the amount of amyloid plaques or the tau tangles and actually correlate how much Alzheimer's disease is present in the brain with how much memory and thinking problems they had. And as you can see from this is, I'm plotting out their cognitive abilities, their memory and thinking against the plaques and tangles of the brain. And you can see that the more plaques and tangles you have, the worse your cognition is, the worse your memory and thinking is. But you can also see that there's a lot of scatter here. And there are some people that have a lot of plaque and tangle in their brain, and yet somehow they're resisting it. Their brain is resilient. Why is it that they are able to tolerate a lot of this bad stuff in the brain without showing the signs and symptoms? So while there's a lot of attention on what can we do to get rid of the plaques and tangles, I also think that, are these people immune to the toxic effects of these plaques and tangles? Is there any way that we can boost our immunity to developing Alzheimer's disease? And so this is, a fascinating line of research that we're involved in. I want to move on to talk about what the current treatment landscape looks like, because, this is a huge disease. Pharmaceutical companies have poured, at this point, billions of dollars into finding an effective treatment. And yet it's been a very frustrating experience so far. Right now, if people develop Alzheimer's disease, we have things like, people have heard of Aricept, Namenda. These are common medicines that are good for Alzheimer's disease as well as some other types of dementia. I say good. I mean, they're used, they're approved, they're not great. Our ability to treat this is really quite, as I tell my patients, we'll start you on Aricept. What we know is that this may provide some modest benefit for some people. You know, that's my ringing endorsement of the medicines that we have. Because it's true. You know, they're quite modest. They do provide some benefit. People who are on these medicines tend to do a little bit better over a longer period of time than those who are not on the medicines, but it's not like the light bulb comes back on. And that's what we want, or that the disease stops. So there's a lot of research going on focused on these plaques and tangles in the brain, and we know a lot about how those plaques and tangles form, and there are, you know, experiments. The way the research goes is that we can design these mice with different genes in them that the mice get Alzheimer's disease. So here's a mouse with some of these plaques in the brain, and this mouse becomes you know, impaired in terms of its behavior and memory. And there are immune treatments, immune therapies that were developed that could actually clear the brain of these amyloid plaques. And so there were some studies that were done, and we ran this study here. It's called bapineuzumab, big name. It's an antibody, an immune therapy that people would come in once a month for an infusion, an intravenous infusion. And in the early studies, you could actually see in this person with their PET scan, you can see the red, the amyloid in the brain, and then after a year and a half or so of treatment with this medicine, you can see less amyloid plaque in the brain, compared to someone who was given a placebo, because all of these trials are placebo, you know, controlled. You know, this person developed more plaque in their brain. So we roll out the study. It's done now in 1,200 people around the world. It was actually it was a nightmare actually, but you had Pfizer and Johnson & Johnson and Wyeth and another company, believe it or not, no, not Merck, working together on this, you know, because everyone I mean, this is such a huge disease that whoever comes out with an effective treatment is going to make a lot of money. Okay, but you know, what happened with the large trial? This is what I call my trials and tribulations slide. You know, and where do we get our news first in this? The Wall Street Journal, because the investors are all over this. And the drug failed. It didn't do what it needed to do. This was a huge, and we've had a number of these, and this has been a huge setback and frustration for us. So but we continue to, you know, to look, and, you know, actually brought up Merck, but Merck now has another medicine that I am extremely hopeful about. It actually prevents the formation of these plaques to begin with, the amyloid. And when I look at the data, you know, at the early data, I've never seen anything as effective as this in terms of lowering the amount of amyloid in the brain. So this clinical trial is now going on. We're doing it at Penn. I think it's also done in Abington, and it's an international study that I think we're very, very interested in. And I sure hope that it turns out to be effective. I think I'm going to skip this. There are a lot of other things that, and it actually shows some of the desperation that people have with this disease. You know, we had this, I'll tell you about it. There was a medicine that's used for a rare kind of skin cancer, something called mycosis fungoides, for any medical types in the audience. And they gave this cancer medicine that's used for this condition to mice that had Alzheimer's disease, okay? And normally mice
keep a neat house. You put them in a cage and you put cotton in, and they kind of bring the cotton together and they make a nice little nest in the corner, you can see here. In an Alzheimer mouse, they have a messy house. Okay, they just don't clean up after themselves. They're not functioning. They're demented. And within a week of giving this medicine, you decrease the amount of amyloid, and they kept a neat house. So this looked really promising. It was published in a very prominent journal. I can't remember whether Nature or Science. And again, what happens? It hits the Wall Street Journal, and this is a medicine that's in use in cancer right now. It's available. It's really expensive. It's like $20,000, $30,000 a year. We were inundated with calls at the Penn Memory Center. I just saw in the Wall Street Journal that there's something that will cure my Alzheimer's disease in a mouse, within a week. And I had. And I actually had the son-in-law of a woman who had Alzheimer's disease. He went out and bought this medicine from a chemical company, and then it was too expensive from that chemical company, so he went and bought it from a Chinese chemical company and was giving it to his mother-in-law. And this is a medicine that is expensive. It's toxic. Your triglycerides go through the roof. It can affect your thyroid gland. But it shows the level of desperation that people have and the level of frustration that they will go to these lengths to find a treatment for this. So that's one kind of story about where the research is and some of the difficulties that we have. Then we have things like this. So, moderate consumption of Cabernet Sauvignon attenuates amyloid neuropathology in a mouse model of Alzheimer's disease. Okay, so, we all know red wine is good for us, and here, I don't know what moderate consumption of Cabernet in a mouse is, but I do know that when we calculate how much you would need in order to do this in a human, it's 187 bottles a day. And that has side effects. But it's an interesting observation, right? So can you distill out the active ingredient? And there's something called resveratrol that you can distill out from red wine, from peanuts, from Japanese knotweed, blackberries, blueberries. And resveratrol is an interesting thing. It actually may be helpful for diabetes, it may be helpful for certain kinds of cancer, and it may be helpful for Alzheimer's disease. So, we ran a study with, again, a national study with about 20 other sites around the country to study whether resveratrol works, okay? The data are still kind of coming in. Doesn't look like it's been any miraculous change, but it is an interesting, it's an interesting notion. This is one of my later, I put this together recently, a few months ago, I was giving a talk up in Boston and I put this together. I actually went through the literature to see how many successful treatments we have for Alzheimer's disease. And we have hundreds of treatments for Alzheimer's disease that can improve the amyloid plaques and the tau tangles and improve behavior, with the proviso that you're a mouse. So all of these things have been described in mice. Some of them are new medicines and some of them are weird things like was one like magnolia extract, grapeseed. These are interesting things. Figs from Oman, dates from Oman. And you know who that study was sponsored by, right? So. But all of these things are very interesting. Some of these are proprietary, and they're patentable. They're new compounds by pharmaceutical companies, and so the pharmaceutical companies are really kind of pursuing it. But others are things, you can't patent grapeseed polyphenols. So this may actually be a really good medicine, but the problem is that we'll never know, because who is going to fund the study that will demonstrate whether it really works it's easy to fund a study in mice. To do 100 people or 200 people takes, $1 million, or several $1 million. So, I think one of our goals is to try to raise money, from philanthropy, from foundations, in order to do studies for things that the drug companies are not going to touch, because they can't really patent it and make a profit from it, but that may be effective. So, while I can say, and a number of these things make a lot of biological sense. And here's another list, and then I've got other slides, just listing all these things that can work, many of which are available now, many of which have been used in other conditions. So, we're interested in Martha Combs, has been the coordinator for a study of metformin. We're very interested in the relationship of diabetes to memory difficulties. And, the most commonly prescribed medicine in the world for diabetes is metformin, glucophage. And it had never really been studied. Does it help Alzheimer's disease? Does it help any aspect of Alzheimer's disease? So we got a small foundation to give us, $300,000 to do a small study to see whether it affects PET scans or MRI scans and spinal fluid. This is how we're trying to move the field forward for some of these other things that are either generic or that are just not patentable. I'm going to close with this study, because one of the issues why so many treatments have not failed or have not been effective for Alzheimer's disease, and what we're thinking of is that once the brain really starts to break down and someone has Alzheimer's disease, maybe it's too late. And so if we can shift it forward before someone has symptoms, if we can see who's on a track for developing Alzheimer's disease and intervene at that point against these amyloid plaques or these tau tangles, maybe then we can prevent Alzheimer's disease. So this is now a study, this is a landmark study that just started about a year ago, called the A4 study. It was developed and it's run, Risa Sperling at Brigham Hospital in Boston. Harvard Medical School is the overall leader of this study. It's being done at 50-something sites around the country and in Canada, and I think in Australia has a site. And it's basically to take older adult volunteers who have normal memory and thinking. Many of them have a family history of Alzheimer's disease. They saw their mother or father die with dementia. So they're sort of motivated to kind of contribute. And they come in and we see if their memory and thinking is normal and that they're generally healthy otherwise. And then they get a PET scan. And we see, do they have amyloid in their brain or not? And if they do have amyloid in their brain, but they're still normal in terms of their thinking memory, can we give them a medicine that is going to prevent, or an immune therapy, actually, this particular medicine, that can break down the amyloid and help clear it from the brain? So, this is a clinical study for people 65 to 85 with normal memory and thinking, who have some concerns about memory loss, who realize that the only way that we're ever going to solve this problem of Alzheimer's disease is if we do the research, and they're volunteering, for this. So, it's a, I think, 2-year study, 3-year study, Martha, 3-year study, and they'll get, I think, monthly dose of medicine. We'll follow them with memory and thinking type tests, and we think that over 3 years, people, ordinarily people with amyloid, a lot of amyloid in their brain, would have some change in their memory and thinking, some deterioration, maybe develop mild cognitive impairment. But with this medicine, we think that we're going to be able to keep them stable and normal, okay? So this is going to be the ultimate, I think, one of the most important tests of the amyloid hypothesis of Alzheimer's disease, as we call it. If someone has amyloid, but they're not impaired, and we work to get rid of the amyloid, can we prevent them from getting worse in the future? And I think that this is a study we're going to learn an awful lot of information from. Okay, so I've talked to a lot. I just want to acknowledge some of the other faculty. The Penn Memory Center is, really a multidisciplinary. We have people from neurology, psychiatry, medicine, geriatrics, neuropsychology, social work, all kind of working together around this disease because it is so multidisciplinary. So I'll stop with that, and I think we have plenty of time for questions, and so I'd like to really develop a conversation here. Hold on, just a yeah.
Hold it right up to your mouth.
Dr. Arnold, there's something in the literature about amyloid plaques, that there are apparently some that are obviously deleterious, but they also say that some are beneficial. And I'm wondering if this amyloid plaque issue, why some people are not responding to it negatively, is that maybe they've got a different kind of plaque. Is that something
Yes.
that's
Yeah, so the question has to do with the amyloid plaques, and this does get into this gets into a complicated and still controversial area, but so and it's one that I'm actually very interested in for a number of reasons, but there's a question: is it the plaque itself that's a problem, or is it the protein, the abnormal proteins that are being created? So the protein is a normal protein. We all make amyloid in their brain, and usually it's just produced and it washes out, okay? For some reason, in Alzheimer's disease, it misfolds and it kind of clumps up into these little molecules, or they call them oligomeric oligomeric amyloid. And these oligomers, these amyloid protein molecules, are thought to be toxic to the neurons. And actually the plaque that is a big clump of all these proteins, and it's thought that maybe the plaque is absorbing all these floating around toxic molecules and just kind of almost like an abscess, or it's just kind of taking all of it and concentrating it and actually protecting the brain from the floating stuff that causes the problem. So, so actually maybe we want to not break down the plaques, maybe we want to actually promote the body's healing by promoting these plaques. We don't know yet, okay, we don't know. Yes?
Are you accepting new volunteers into this program?
Yes.
Everybody hear that?
Yes, we are. So we are. Right now we have a number of research trials going on. We have we're looking at new ways to diagnose the disease with different kinds of MRI scans, but we have what we call our longitudinal cohort. So people who want to come in, like those nuns and priests and that I've mentioned, who will be come in once a year for some memory and thinking type testing, and who may be interested in donating their brain to science afterwards, after they've had a good long life using their brain, let it continue to be useful for society. We have that. We have this A4 study that I talked about. We have other studies for people who already have mild cognitive impairment. So if you just want to let your name and contact info, we can contact you and sort of see what you're interested in, tell you what we have available, and would love to make a match.
Actually, I have two questions. Number one, is there any study on viruses possibly caused by some viruses that causing all these clumps? That's the first question. Second question is that when you present about the people who have a lot of this amyloid plaque and so on, but yet they don't have these symptoms, is there any study about non-drug type of intervention, like more social wisdom, social interaction, community links, and all that?
Yeah. Okay, so, wait, this is my working memory. Your first question. Oh, the virus, yes. Yeah, so there's been, there was actually a lot of interest in that because they, looking at where these plaques or these tangles form in the brain, it looked like in some of the olfactory regions of the brain, for, the nose and sense of smell, which of course we get a lot of, head colds and viruses. Could that, something kind of go into? All the studies about viruses, and people have been interested in this and studied, in many, many ways for a long time, it does not appear to be any kind of viral mediated thing at all. So I feel pretty secure, pretty confident in saying that. In terms of, this is a whole other lecture, in terms of things that we can do and the non-pharmacologic interventions. And a lot of these are based on some of the risk factors that we see for Alzheimer's disease. So I mentioned a lot of like the cardiovascular risk factors, the high blood pressure, sugar diabetes, things like that. We do know, and we talk about this a lot with our patients, the importance of these other non-pharmacologic interventions for improving brain health, whether you have a disease or whether you don't have a disease and want to prevent it. And the data just keep coming in that physical exercise is really important for brain health. Okay, sometimes exercise is a toxic word, but activity, physical activity, just moving, being, moving is really important. We talk about mental activity, mental stimulation being very important. So exposing yourselves to new things, challenging yourself and learning new bridge, how to play bridge if you don't play bridge, exposing yourself to, going to museums, going to movies, being out, being active, being engaged mentally, challenging, not overstressing yourself, but challenging yourself with new experiences is showing itself to be healthy at improving memory, or at least keeping it alive. Social engagement there's probably nothing more stimulating to the brain than interacting with another person. You're hearing something new, you're reading their face, you're interacting, it's extremely stimulating. And one of the issues that we have with older adults is that, it's harder to move and your knee is bothering you and it's cold outside, and, you don't want to go outside. So people tend to stay more isolated. And with that isolation, there's less stimulation to the brain, there's less physical activity, and people fail. And so I think that, staying socially, what we might call social exercise, social engagement is just absolutely critical. And then the other major thing that we talk about is, is nutritional things. And right now we feel that the Mediterranean diet, which many of you probably have heard about, is probably the most heart healthy and the most brain healthy. Just think, what's good for your heart is good for your head. And so, lots of fresh fruits and vegetables, more whole grains than refined carbs and things like that. Not much meat. A little meat is fine every now and then. More fish. Extra virgin olive oil, and there have actually been some controlled, placebo-controlled studies of extra virgin olive oil, and it shows definite benefit to brain health and memory in this large study that was done in Spain a while back. A glass or two of cab, or actually Pinot, not 187 bottles, but a glass or two of wine is fine. It's good, I think. In the most common, by far the most common forms of Alzheimer's disease, which is late onset Alzheimer's disease, people in their 70s and 80s, it's like any health problem. If your father had heart disease, you're a little more likely than the rest of the population to have heart disease. So yes, if your father or mother had Alzheimer's disease, you're a little more likely than regular, but not a lot more likely, okay? So for typical late onset Alzheimer's disease, there is a small hereditary component, but it's not a very strong one. In the rare forms of early onset Alzheimer's disease, people who develop it in their 50s, then the genetics are much stronger. Okay.
And can it be related to post-traumatic stress or surgeries, long surgeries, where you're under anesthesia for a long time?
Yeah.
Can
Okay.
that cause-
So then that's yet another, and I have a whole other kind of interest in the relationship of stress, whether we're talking about physical stress or emotional stress, and what toll that has on the brain. So, the question is, does post-traumatic stress, or do things like, hospital and anesthesia, are they related? What I can say is, yes, they are related. I don't think they cause Alzheimer's disease in terms of the plaques and tangles, but what I think is that major stressors, whether it be emotional stress, major emotional prolonged stress, depression, major anxiety disorders, or major physical stressors like being in the hospital. I'll talk about anesthesia in a minute, but that these basically, they make the brain more, it's like kind of like a wear and tear effect on the brain, so that the brain may be less resilient, more vulnerable to a little bit of plaque and tangle that develop in the brain. And so people may, with a long history of depression, post-traumatic stress disorder, multiple surgeries or illnesses, they may be more vulnerable to developing Alzheimer's, but they don't, or to showing Alzheimer's disease, but it's not like it promotes the amyloid plaques and tangles. Now, the issue of anesthesia, because this is a very common question that we're getting, and people are afraid to get surgery because they think that the anesthesia is going to cause the Alzheimer's disease. As we've learned more and more about this over the last few years, it does not seem to be related to anesthesia. It's not related to surgery per se. It's related to the fact that you're getting the surgery and the anesthesia because of some problem. You break your hip. And that, when you break your hip, you get sick. There's a flood of inflammatory things that are circulating, and that can have a deleterious effect on the brain. Okay.
Is Alzheimer's an inflammatory disease?
There is an inflammatory component to Alzheimer's disease, and that's a whole, it's complicated because it's more than just plaques and tangles. It's inflammation. It's what we call oxidative stress and damage. It's like all these things coming together that lead someone to develop dementia. And so there's a whole other avenue of research on inflammation, and because it's interesting, people with rheumatoid arthritis who take a lot of anti-inflammatory medicines throughout their life, they have a lower risk of developing Alzheimer's disease. So then there were studies of, let's give someone prednisone, or let's give someone, large doses of Motrin or Naproxen or some of these other anti-inflammatories. They didn't show any effect in people with Alzheimer's disease. But the issue is, was it too late? Should they have been treated, 5 years before they developed it? And that's what we just don't know yet.
Doctor, are there any international populations that have a low incidence of Alzheimer's? You hear these studies about the Japanese don't get cancer, and the Swiss don't get this. Is there anything in the world where what we do differently in the West, what we do in America, might cause Alzheimer's, and it's not happening in other parts of the world?
Yeah. So to that question, so the question is, are there any populations around the world that don't have Alzheimer's disease? And basically the answer is, there are some pockets, so like in Okinawa, where they have a very, particular lifestyle of very healthy diet, they actually eat on the floor, so they're constantly getting up, going down, they're getting a lot of physical exercise, they're very lean, there is a slightly less rate of dementia. But basically, the biggest risk factor, bar none, is age. So, there's a low rate of Alzheimer's disease in Africa. People just don't live. Yes, in the back.
There's a little known event that happens, and I have had experience with at least 3, called transient global amnesia, which is happens that a person, for no particular reason that one can identify, loses short-term memory. And if it is truly transient global amnesia, that short-term memory comes back within about 24 to 48 hours. The first time I experienced it was not with myself, but over 20 years ago. And at that time there was no internet and no way that you could explore this. And the tiny bit of information I could find really said it was so seldom that it happened that there was no great research. I am wondering if that event is a precursor in any way, because it's so seemingly insignificant. Has there been any follow-up with people who have had this encounter with transient global amnesia? The person who experiences has no memory of what happened within that 24 to 48 hours. They are not ill, they have a flat affect, but they can remember things from the past, which is not too unlikely, the long-term memory. So have you any?
So this is it's a very rare condition. And in a word, it has no relationship to Alzheimer's disease. Okay. The transient global amnesia, as you described, you very richly described it, very nicely described it. It's a brief period where it's just someone is like totally amnestic, and there have been people we don't understand it well. There have been some people have tried to relate it to migraines, to mini strokes, or some kind of could it be related to stroke or vascular changes. We don't understand it very well, but what we do know is that it has no kind of statistical relationship at all to Alzheimer's disease.
Thank you.
I didn't. This side has been. I've always been looking at this side. Yes, please.
How much truth is it to the fact if you have runs in your family in the 70s or 60s, the chances of it occurring 20 years prior to people like myself or siblings, that they could be going on 20 years prior to when they had it?
So the question is, if someone in their family, if a mother or father or someone has late onset Alzheimer's disease occurring in their 70s, or what we call late, I mean, I don't think of 70s as actually late, but I don't. But it's still technically what we call late onset Alzheimer's disease. If there's late onset, does it increase your risk for developing early onset Alzheimer's disease, let's say in your 50s or 60s? Very little data to suggest that it does increase it. I don't think so. That doesn't mean that, we don't see people in their 50s who get it out of the blue without any family history. But that is rare, and I don't think the later the onset is of Alzheimer's in your family, the less likely it is to be hereditary.
But what if it's earlier?
What do you mean? Early onset?
60s and 70s
Yeah.
in my family.
Okay. And so if it happened, then it again, it's sort of a gray area, and we don't really know. My suspicion is that there may be a little more than a little hereditary, but not much more hereditary risk for you. Okay. Yes?
Two questions, one serious, one not. Can we get a study funded to test the various brands of Cabernet?
Well, if anyone has some resources here that they, I would definitely have a, we can do that. We know how to design a study.
That was the serious question. The serious one. How close are we to doing large-scale screenings for the preclinical conditions? Among the, the most likely.
Yeah, so here's the, so how close are we to doing large-scale preclinical screenings for Alzheimer's disease? And this is a controversial thing because right now we don't have a clear, effective treatment. So, even in Forbes magazine, so when some of those PET scans came out, and they were actually approved by the FDA, there was an article in Forbes, that here, go get your PET scan, see if you're amyloid, that you're going to get Alzheimer's disease, have a nice day, because there was nothing really to do to treat it. So it all depends, I think, but then the Alzheimer's Association, and this is, I think it's a worthy and I think we have different and legitimate ways to think about this. If I had a crystal ball to tell you that what your future was going to be in 10 or 15 years, but there's nothing you could really do about it now, would you want to know? Okay? And some people would want to know. They'd say, well, okay, life is, so I know that life happens, and in 20 years, I'm going to get dementia. I want to, no, but one person wanted to, well, some people would say that, and I don't condone that. But they would say, well, geez, I'm going to live my life a little bit different, or I'm going to prepare my family or my finances in a certain way that can accommodate it so that it's not stressful for my children. They're more attentive. What's that? Oh. Other people would say, well, if I can't do anything about it, why do I want to know? I like my life the way it is. I'm just going to live it, the chips fall where they may. I think both of those are very legitimate. It's a personal thing. It's actually interesting that, so there's a gene, something called the ApoE gene, the apolipoprotein E gene. And if you have type 4 of that gene, your risk of developing Alzheimer's disease at some age, we don't know what, is about 2 or 3 times the general population. And so they did a study about what is it, if we told you what your gene, would it change your life? Knowing that you have a higher risk of developing Alzheimer's disease. And the big study, there wasn't more depression after people found out that they had E4. There wasn't, people didn't commit suicide, nothing like that. The only thing that people did, if they found out that they had E4, they were more likely to buy long-term care insurance. So that's the only, that was the only real impact that had. And this is actually interesting. So I talked about that A4 study because we are having people come in who are normal. Maybe they have a family, and we are telling them they have either amyloid in their brain or they don't have amyloid in their brain. And we are asking them questions to determine what effect does that have on you? How does it change your thinking? And some people are saying, well, I'm glad that I know this, and now I can participate in this study. We don't know if the drug's going to be effective or not, but at least I'm doing something about it. And if it's won't help me directly, maybe it'll help what we learn, we're going to help someone else. So that's great. Other people say, we're concerned about. Now, the whole game changes if we have an effective treatment for this, okay? So it's and then we say that, right now you could say there's no effective treatment, what, you're going to do this expensive test, $4,000 to do this PET scan, and you're not going to be able to do anything about it. Why spend that kind of money? But I think that if we did have an effective treatment, then, you turn 50 or 55, you get your EKG stress test, you get your colonoscopy, and you get your amyloid scan. And if any of those are positive, you do something about it. And that's what we want to achieve.
Use your short-term memory earlier than the long-term?
Yeah. So we know how people change with the development now. And the question is, do you lose your short-term memory or your long-term memory? And short-term memory is the thing that is first and foremost effective in Alzheimer's disease. So you can remember everything about your childhood and your past relationships and things like that, and but you can't remember what you had for breakfast, or if you had breakfast. That's where things but then as the disease progresses over the years, then those other aspects, the long-term memory, does get affected. Yes. Yes.
When I had my physical last month, the doctor asked about 7 questions, giving 10 words and doing them backwards.
Well, I'm impressed.
And
That's
he
good.
said it was now part of the physical, and like Medicare asked for.
Right.
Would he be using that information for any reason?
That information is very useful. Medicare did now has required that people get a brief screening for memory loss and dementia. I think there's a lot of reasons why to do that, and I think that that's actually very good. How many doctors are actually doing it? I don't know, because a lot of doctors, like us, you feel frustrated at what you can do, so you don't even want to know. And if you don't ask, you'll never know. But it does affect, this is a huge thing, because people who have memory difficulties forget to take their medicine. They forget to take their medicine, their blood pressure goes up. They forget to, their blood pressure goes up, they get a stroke. So it's important to recognize when there is memory that even if there's no pill that you can give to cure it, you can at least sort of help someone with the other aspects of their life. Yes?
Ed and I have been reading recently that they're concentrating more on the tau than the amyloid.
Yes, so amyloid is, there's a lot, so the question is, are people concentrating more on the tau than the amyloid? And the answer is yes. And this is very complicated. I actually, we used to divide ourselves into what they call the Baptists and the Taoists, the beta amyloid protein, and then the Taoists. And I've always been a Tao. So amyloid is present, and it's the sine qua non of Alzheimer's disease. But whether amyloid is doing the damage or tau is doing the damage, there's a lot more evidence that the tau is what's actually doing the damage. But the amyloid is fuel for that fire, okay? And so both are important. And there's more emphasis. Amyloid is a much easier thing to measure. It's a much easier thing to treat, or at least in mice. Tau has been more difficult, but tau is catching up now, and there's a lot more attention on tau, and it is still more difficult, but you're right. Yes?
There are lots of people on these medications that you say really aren't doing much. Do you feel that they at least help slow the progression, or even though they're not treating the disease or curing it? Is there any research that shows any except for, spend a lot of money?
They provide, so that's,
Can you repeat the question?
so the question is there any, with all the medicines like Aricept, Exelon, Reminil, Namenda, that really are quite modest in what they do they really help, and is it worth spending the money for them? And, I think the studies have shown that you take 1,000 people and you average the benefits of 1,000 people on the medicine versus 1,000 people on the placebo, that the people on the medicine do a little bit better, a measurably amount better. What does that translate to? Is it clinically meaningful? You know, sure, we can do these scales. So they've done things like how many years before a person needs to go into a nursing facility. And they find that the people on the Aricept or the Namenda can stay at home an extra 6 months before they go on. And that's clinically, that's statistically significant benefit. Is it clinically meaningful? I don't know. For some people, yes, but for others, I don't know. And so I think one of the things that I say, like with these medicine, well, it doesn't really seem to be doing much, doc. Do I need to stay on the medicine? And you know, a lot of times it does come down to a financial thing. I would not break the bank in order to stay on these medicines if it doesn't seem to be doing anything. But if you're just paying a $5 or $10 copay, and it's not causing any side effects, maybe it's doing some benefit, and the studies do suggest it provides some modest benefit, so let's stay on it. And that's all I can say.
Wow, that was fabulous. Thank you,
Okay.
Dr.
Okay. Thanks.